Hello, class. Sorry I couldn't be there with you today, but this is my presentation on nurse screening for depression and suicide risk in the pain clinic. Here's my board. I know it's kind of difficult to see, so we will be going through a presentation and you'll be able to see things. We're starting up here with the introduction information. So the current policy in my facility is that suicide and depression screening assessment, I'm sorry, not screening, but assessment should be completed by providers during the annual assessments. There are also other times when veterans who are still currently active duty might get assessed, for example, immediately before or after a deployment. And then they're supposed to be screened when certain medical conditions exist. And there's a little bit of information on that, but it's not super clear cut. Also, they should be screened whenever a clinician sees it appropriate because of presentation. But none of this is super clear. None of it is specifically at this moment they need to be, or these are things where it must happen, where it's watched and monitored, and that we're making sure that all of the needs are being met. In specialty care, the nurse manager identified the percentage of patients being screened was actually less than the number of veterans being seen annually, indicating that the policy that currently exists isn't even being met, let alone these extra things like referred or self-referred or indicated by presentation, and that is a problem. So the problem we have here is that American veterans die by suicide disproportionately more frequently than the civilian population. There's not a policy on how, when, or by whom these assessments occur. It's not clear cut. Suicide claims, we all know the 22, right? Or those of us who have military affiliations know about the 22 veterans a day. There's a lot of things that are done for awareness with this. There's the 22 push-ups, that a lot of people posted. It's a challenge that people were putting on Facebook that they do 22 push-ups for 22 days and then post them on Facebook or whatever social media platform they use to raise awareness, and then call out other people to also do this. Lots of different things with that. But the big barrier to these veterans self-referring or looking for help is that there is stigma affiliated. They're embarrassed. They believe that others will lose confidence in them. They fear consequences. They don't want to be viewed as weak by people they currently work with or previously have worked with, or family members, or even their clinicians. And then for many who would seek help, they don't really know where to go, or they believe that it's going to cost too much, it's going to be too hard, or that there's going to be certain strains on them. So they're not seeking assistance. Moving on to opportunities that we have here, opportunities for progress. The associations between pain, depression, and suicide are well established. In the United States, fewer than 100 suicides per year over the past several years occurred in healthcare facilities, which means that there needs to be another way of catching these. And the outpatient environment is one place that we could be catching them. There's a lot of patients that come in for specialty care. They only see their, say, cardiologist, but they're no longer seeing their primary care, so they're not getting all these annual screens. My policy proposal is that there's an addendum to, or creation of, a new policy that includes nurse screening in the pain clinic of the facility where the population is more vulnerable. And this applies specifically to my facility, but it definitely applies to other facilities as well. This is not just veterans that are in pain, in chronic pain, that also have depression and suicide risk. It's all people. Related topics for us as nurse stakeholders. In the conference, there was advocating for your patients, which this definitely is. This is making sure their needs are being met, even though currently they're being missed by clinicians. Uncomfortable conversations, asking somebody directly, how often do you feel depressed? Or do you ever think that it'd be better if you weren't alive? These are uncomfortable conversations. And incivility issues, specifically related to the stigma. Even nurses have really negative ideas about suicide and depression, and unfortunately, we have patients that say they don't even want to talk about it with their healthcare providers because they fear that those people are going to look down on them for it. So there's a lot of work that needs to be done, and the nursing staff is the right people, or the right people to be doing that. The meaning for nursing in healthcare, nurses are the front line for the patients. Unlike providers, we always hear that with nurse practitioners versus PA. The big difference is that nurse practitioners are nurses who practice and they're looking at the patient. And the PA is it's a physician's assistant. So they are more disease focused. We're the front line for looking out for our patients, and this is looking out for our patients. Next steps. So the first thing that we needed to do is write a policy that required nurses who screen patients for clinics to conduct a depression and suicide screen. The next thing is we need to train the nurses that will be completing the screen. As I said, that there are really unscientific views out there, even among nursing staff, about suicide, and we need to prevent any incivility that a nurse might inflict upon a patient. We need to make the screening possible, which is a two-part thing. One, the staff has to have the logistic training. They have to be able to access the documentation tool showing that it's done. They need to know how to actually just do the screen. And then we need to ensure that the electronic screen is available and can be accessed at all times within the facility and system. We need to make sure that the screen is easy to do. So there should be, in the regular documentation that a check-in nurse does that has vitals and checking meds, whatever, there needs to be a place where it says if the patient meets certain criteria, then you now also have to do this screen. And it should either fill in or it should take you to a link, but it should be something that you can't just, oops, I forgot to do it. It has to be something that visually is part of your documentation. You need to make the actions clear. So there should be some kind of a flow chart that provides clear, easily visual representation for the nursing staff to follow to determine, does this patient need to be screened or not? And then what do I do if the screen is positive? The policy models that we're looking at here is one, incrementalism. The policy is built on previous policy using existing screenings that already exist in the EMR. Most facilities, mine certainly does, has some kind of a screen. So you're just pulling something that already exists and fitting these puzzle pieces together. Then the policy is a process. Policy is a process. The problem is defined. Here we defined the policy implementation, later evaluation. So these two theories or models are what would come into play with this particular policy. So the policy of incrementalism, or the policy model of incrementalism, is clear in the goal setting for this policy. Each goal builds upon the last. So the first goal is the clearest with this screen, or really any screen, which is identification. So we want to increase the number of patients who have severe depression or suicidal ideation who are identified. The second goal is to, among those patients who have been identified, who have chronic pain, who have complaints of or identification as having severe depression or suicidal ideation, they are assessed by the appropriate clinician, by behavioral health, by primary care, that those next steps are met. And finally, the ultimate goal, of course, is decreasing the incidence of suicide. And these goals will be measurable over time. So the number of patients who are identified would be apparent almost immediately. As soon as this policy is put in place and the access is created, then there should be a very quick increase in the number of veterans, of patients who are identified as needing that next step. And then the number of patients assessed would be the next thing that became apparent. And over time, we would hope to see a decrease in the instance of suicide. Ethical considerations. First one is a need to act. If we identify the potential risk for these patients, then we have to do something. We can't just say, okay, that guy might need some help, and then not give him the help. So the next steps need to be clearly defined and easy to follow for the nursing staff. For example, the nurse can't let a patient go home if they have said, yes, I am having thoughts of suicide. Next thing is false positives. This is a screen, not a diagnosis. The procedures associated with the policy should minimize the negative impact on the patients who are identified, particularly those who are inaccurately or accurately. Stigma, status, time and money for additional services. We need to try to minimize all of that, particularly with false positives. False negatives. Some patients with depression and or suicidal ideation might be missed by this screen. So this screen should supplement, not replace, other identification measures that are already in place. Fourth is stigma, civility, self-esteem. Training is necessary for the nurses that are conducting the screen. It's also necessary for the clinicians who do the secondary assessment. We want to avoid negative connotations, judgment, and we want to work to support and empower these patients who are needing that support. Next is the policy analysis, pros and cons. So time and money we always address, of course. The pro is that having the screening happen at the time of other appointments, it's going to eliminate the need for some separate clinic or for increasing the primary care clinic. It's going to hopefully prevent suicide. That's an obvious plus. From time and money perspective, it decreases rehospitalizations and there's financial savings associated with that. Cons are it's going to possibly require additional staffing. If we're identifying enough people, there may be a need of help at some point down the line. There's going to be additional training for the staff that's screening. That's time and money. It's going to potentially increase the duration of patient check-in and visit. Typically, these screens only take 5 to 10 minutes max, but if you have 20 patients in a day, that can be really significant, so that's going to have to be addressed. And we need to consider, is this additional time billable? Can it be sent to TRICARE or Blue Cross Blue Shield? I'm not really sure about what will happen with that in the future, and we're still looking at that for next steps. Currently, we have implemented this process in the last couple of months where I work, and we have not found that it's taking enough time that we need to worry about it just yet. But as it progresses, that might be an issue. For the patients, pro, it provides access to support that a patient might not otherwise be aware of. If they say, yes, I have depression, yes, I have these thoughts, then we can say, hey, we can get you help. We have services available. And they might not have known that before. It could interrupt the process if a patient was having really severe thoughts that day, and it doesn't require an additional phone call, an additional visit, or any additional effort on the part of the patient. If they've already come into the pain clinic because they're hurting, then this is an extra step that they're not having to take. Downsides for the patients is the facility visit takes longer. They might have only timed out 30 minutes, now it took 35, or if they had a positive, if they were identified at risk, it could take quite a bit longer. And also these screens sometimes are viewed as irritating. The patients don't want to go through the process of asking or answering questions related to screens, the alcohol screens, the tobacco screens, the suicidal ideation screens. Some people find it to be irritating. For staff, a pro is that it allows that initial uncomfortable conversation to be addressed by a nurse rather than a practitioner, which we discussed earlier. And the cons is that it's going to increase time for admin, for auditing of charts, for example, and the increased workload. So this is the flow chart that I made, which was really fun. I've never made a flow chart before, so I had to do some research on what the different shapes and symbols mean. But this is actually exactly what now is available to everybody in the specialty care clinics at the Robert J. Dolvier Medical Center. And on this one, it says behavioral health, and there's little like hashtags, but there's actually the phone number that people call to reach a person. And the behavioral health refusal team, if they were positive for depression but negative for suicidal ideation, we would contact the behavioral health refusal team. And these are people who follow up to make sure that these patients receive some kind of support and services, or at least have information and access. They actually send out a packet. And then the emergency department, if you get a positive for suicidal ideation, then you've got to be able to pass that patient off because you still have a clinic to run. So it's one-to-one with an escort and monitoring directly to somebody in behavioral health, and if not them, then emergency department. So this flow chart takes you through the steps so the nurse doesn't have to do any kind of critical thinking. They don't have to make a decision. They just follow the decision tree. So you assess the patient. Are you seeing a need for a screening? If you don't see a screening, move on. Check the reminders. Are they here for, or is the screen due? Have they not had an annual screen yet? And if the answer is no, consider the clinic. Are they here for pain management? And if the answer is no, they don't need a screen. But if the answer to any of those are yes, then they need to have that screening. And then the steps on the right side here shows what you would do if you had a depression negative, suicide negative, depression positive, suicide negative, and then regardless of what you got for depression, if they said yes, they're having suicidal thoughts, those are the actions that you would need to take. Future advocacy. So one big thing is we want to expand the initiative to include specialists who interact with populations who are more at risk besides just the pain clinic. So this includes cancer patients who have independent risk for both pain and depression, patients with rheumatologic conditions because those conditions are characterized by swelling and pain and long-term treatment, and it can be treated but not cured. Patients who are followed by orthopedic department, particularly for chronic conditions, if they're getting regular injections, that is going to be a long-term chronic pain situation, regardless of whether they're being followed by the pain clinic. Patients prescribed any kind of long-term analgesia, particularly narcotic analgesia, because that's chronic pain. It's the same thing, it's just a different clinic. And this policy is just one piece of the puzzle and one part of the process. So the policy as a process is, depending on which resource you use, it has words like define, design, adopt, implement, evaluate, which sounds a lot like the nursing process for me, so it seems like it's fitting. And then we have it kind of touches on the scientific method and the incrementalism with, we already have a screen and it's already supposedly happening in this environment. Now we're going to expand it to another environment, and we're going to be in the evaluation portion looking to see how effective it is before we move on and also apply it to other environments. These are my references. I'd like to thank you guys so much for your time, and I am available on FaceTime or phone call or email. Facebook, you all know multiple ways, hopefully, to reach me, and I really look forward to any pointers that you have, because as I've mentioned through this, we actually rolled this out where I work and we're doing it. So if you have any tips for how we can make this be more effective or have more impact, then I would love to hear it. And that's what I have for you today. Thank you so much for your time.